we performed this study in collaboration with Tulane through the Prostate Cancer Clinical Trials Consortium. I think most people know what is PSMA. I think most people know what is lutetium-177, PSMA-617. But by way of background, a couple of points. One is that there were never really any formal dose escalation studies. Number two is that the regimens are based upon, expert opinion, but, not really formally ever really looked at. And then we came in with a bunch of prior studies using lutetium radiolabeled antibody. So essentially we put that all together and performed a phase 1 dose escalation portion using our dose intense regimen, where the entire activity is given in a single cycle, day 1 and day 15. And then following that dose escalation phase 1, we went on to assignment 2-stage phase 2 study. This dose intense regimen is also designed to get around repopulation as a mechanism of resistance. So in terms of the actual study, relatively kind of normal inclusion criteria. So progressive metastatic CRPC by working group criteria. A couple of points about the patient population. One is that we did require a normal neutrophil count and platelet count, so it's a little stricter than typical. And the other is that this was not a PSMA-selected patient population. All patients had PSMA imaging, but that was not used for study entry. The phase 1 dose escalation portion of the study was presented at ESMO 2018. And basically in the 5 dose escalation cohorts going up to 22.2 gigabecquerel in a single cycle, there was no DLT. So the recommended phase 2 dose that we used for phase 2 was 22.2 gigabecquerel, so 11.1 given on day 1 and day 15 of that cycle. We present the overall patient population. The details are in the poster. Overall, what we'd expect a reasonably heavily pretreated patient population. Most had at least 2 lines of prior potent AR pathway inhibitors. Most had chemotherapy, but not all. Some not significant minority received radium and 6-T. And a couple of patients also had previously received lutetium PSMA targeted therapy with the antibody. Overall, I'd say despite a reasonably heavily pretreated patient population and without selection for PSMA positivity by imaging, the majority, as those of you that can look at the poster, see in the waterfall plot, the majority had post-treatment PSA declines, with 52% having at least a 50% PSA decline. And, compared to historical controls for the overall population, some of the Kaplan-Meier curves look interesting compared to historical controls, with a median biochemical progression-free survival of about 3.5 months, median radiographic progression-free survival of about 9.5 months, and a median overall survival of 15 months. I mentioned there are no DLTs in the dose escalation portion. The regimen was overall reasonably well tolerated. All of the non-laboratory AEs were low grade and, generally speaking, of a short duration, the most common being xerostomia and nausea, as expected with this agent. Hematologic toxicity was also generally low grade. I'll mention the grade 3-4, so 12% had grade 3-4 anemia, 2% thrombocytopenia, and 4% neutropenia without neutropenic fever. I mentioned that there was no criteria for positive PSMA imaging to get into the study, but the majority had at least weekly positive PSMA image, and when restricted to PET, approximately 80% had at least one lesion with an SUV max of greater than 5 times the liver SUV mean. So in summary, this single cycle of dose-intense administration of lutetium PSMA-617 is safe at 22.2 0.2 gigabecquerel in that fractionated dose. And interestingly, I think in a pre-treated patient population that was not selected for PSMA expression, most had PSA decline, respectable PS response. I didn't mention also CTC count control. Overall, radiographic progression-free survival and overall survival are favorable compared to historical controls.